Hello. Wherever you are in this world and whatever time of the day it is for you, I want to welcome you to the CTSNet live webinar. On behalf of our panelists, my name is Ed Chen. I'm an adult cardiac surgeon at Duke University, and I welcome you and thank you for your interest in today's topic entitled Aortic Root Enlargement, New Insights and New Technologies. We are fortunate to have three globally visible and recognized experts in aortic valve and aortic root surgery. Duke Cameron from the Mass General is an adult cardiac surgeon in the Mass General. And we also have Dr. Maral Uzunian, Associate Professor at Toronto General Hospital, University of Toronto, and Dr. Bo Yang, Associate Professor at the University of Michigan. Each of these experts will speak on varying topics within this subject matter, including valve sizing, patient prosthetic mismatch, various techniques for aortic, annular, and root enlargement, as well as clinical outcomes of these operations. I want to thank the CTSNet for putting on this webinar today. And for the audience, I encourage you to use the chat function to ask questions, which we will filter and have discussions after each talk. So without further ado, the first talk will be Dr. Duke Cameron from the Mass General, and his lecture is entitled Introduction to Valve Sizing and Patient Prosthetic Mismatch.
Thank you very much, Ed. It is a pleasure to be on this panel and to present this talk on valve labeling and the issue of patient prosthesis mismatch. I think it's obvious to everyone why this is an important topic, and this is, of course, the most common reason that we are contemplating aortic root enlargement. So this is a very short and a very basic talk because I think people are familiar with the concepts. The talk I'm going to give mentions a few references, and rather than you trying to scribble those down real quickly, you can feel free to send me an email to this address. And if you just put CTSNet or aorta or aortic root in the subject line, I can send you those papers and a copy of these slides so that you don't have to take notes now. We all recognize the importance of patient prosthesis mismatch. This is a concept that's been around for nearly a quarter of a century. Drs. Pibereau and O'Neill have written extensively about this. There's a very nice review in Heart in 2006, which I really encourage you to read. The definition, of course, is when the prosthetic valve is too small for the patient. It's clinically significant in perhaps 5 to 10% of aortic valve replacement patients. It's defined as severe when the indexed effective orifice area is less than 0.65 centimeters squared per meter squared. That, of course, the indexed is just when you divide the effective orifice area in centimeters squared by the body surface area. Most importantly, a significant PPM leads to higher morbidity and mortality. It's evident perioperatively at 1 year, at 5 years, and 10. It is responsible for persistent symptoms and even accelerated bioprosthesis degeneration. There's a very nice paper in the European Journal of Cardiothoracic Surgery from 2 years ago, a meta-analysis of over 100,000 patients that identified the frequency and the consequences of PPM in surgical aortic valve replacement, and shows that the odds ratio of mortality is increased to about 1.5 in the presence of moderate to severe PPM. Even moderate PPM contributes to mortality. So the problem is very important. Now, there's a very nice, simple algorithm that appeared in an article by Catherine Hotto in Heart 2 years ago that kind of outlines the way we approach these patients. And I know you do this too, but it's nice to see it in a simple graphic. So a patient is presented for an aortic valve replacement. There's often a discussion first about whether this is a mechanical or a biological valve. And the surgeon may have a preference of a particular type of bioprosthesis. But as I'm about to point out, there's a very broad range among the commercially available bioprostheses in terms of how well they perform. And based on an indexed EOA and what's known about each of these valves, one can, with a certain degree of surety, predict patient prosthesis mismatch. And if it is suspected that the indexed EOA is going to be greater than 0.85 with that prosthesis, one can proceed. But the question comes up, given the prosthesis you have in mind, given the size of the patient, what do you do if that indexed EOA is less than 0.85, getting closer to that 0.6 that I mentioned before as approaching severe? Your options are to choose a prosthesis with a larger EOA, and I'm going to talk about that in a minute. And another option is to enlarge the aortic root, which is what the two speakers following me will address. But in some situations, one might even consider replacing the root, and this will also be addressed in subsequent talks. But always remember, too, that there are some patients where a minor degree of PPM is probably acceptable. Older patients, patients who are not physically active, patients who've already had multiple operations on the aortic root, it may be safer to just accept a certain degree of patient prosthesis mismatch. I'm grateful to Chart Ebbels, a Dutch surgeon who's taught me everything that I know about valve labeling and the patient prosthesis mismatch issues. Here's just a sample, a collage, if you will, of all of the labels of the various commercially available valves now and how much information there is on these. But the point I'm going to make is that, unfortunately, with most valve labeling, the number that you really want to know, that is the internal diameter of the valve, that area through which blood will pass, is usually not contained anywhere on this. The closest approximation is the so-called valve labeled size, but as you'll see, that does not have necessarily a direct relationship to the actual orifice size. So here is the problem. One manufacturer's 23 is not the same size as another manufacturer's 23, and even the sizers are different. The true internal diameter of some valves, and I'm talking mainly here about bioprosthetic aortic valves, the true internal diameter is sometimes 2 sizes smaller than the labeled size. That's actually a 4 millimeter difference. And these discrepancies become more important with the smaller valves. How did we actually get here? How is all of this so discrepant? Well, it turns out if you go back about 15 years and you look at some of the standards that were published by ISO, introduced this concept of tissue annulus diameter. That's a term we rarely use in surgery, but this is essentially just referring to the diameter of the tissue annulus after the patient's native valve is excised. And the manufacturers were allowed to label the size of the prosthesis based on the size of the annulus for which it was intended. But there's a lot of leeway there in both directions. And unfortunately, label size has drifted, if you will, from, in some cases, the true annulus diameter. You can put almost any size valve you want if it's supraannular on the tissue annulus. But the relationship between tissue annulus diameter and the internal diameter of the valve is not always the same. Now, part of the problem is that we haven't standardized the description of the valves. You know, what do we mean by an external sewing ring, an internal diameter, a stent diameter, stent height, things like this. These things need to be better defined. In particular, how do you define the internal diameter? I've learned that it's not such a straightforward task to decide what is the diameter of a bioprosthetic valve. Do you measure it with a dilator and pass it through? Well, you know, one of the problems is that the diameter is different at different heights of the valve. Some of them are actually a little restrictive at the top. Do you measure it by putting a known flow across it, measuring the pressure drop, and then calculating the valve area? Do you do it optically? There are actually several ways to do this. It's not clear which is the best, but we do need to agree to all do it the same way. And even the assessment of the hemodynamics, measuring flow across a valve in vitro, is actually not a trivial exercise. And determining how the valve is going to behave under hemodynamic circumstances is a challenge. We need more stabilization on all of these. There's too much information on this slide, but all I want to make with this slide is to show how 4 different valves, and I've covered these to kind of de-identify which valves these are. Valve A, valve B, valve C, valve D, different manufacturers. Here is the measured tissue diameter, or what we would just call the annulus diameter. And here for each of these valves, what the label size is. Then there's an internal orifice diameter measured different ways. And all I'm going to point out here is that there's a lot of discrepancy. In this valve, it's a 2 millimeter discrepancy between the labeled size and the true internal orifice. But in some of these others, it's as much as 4 millimeters. It's quite discrepant. And we need to realize that every time you pick up a valve and you see that label in there on the box, you should be asking yourself, what is the true internal diameter? The data are out there, but you need to know it even before you open the box. Now, we recognize this as a challenge for practicing surgeons. And 3 years ago, almost 4, a special task force was created by the AATS, the STS, and the EACTS to develop a workforce that could address these problems of inaccurate valve labeling and to try to standardize this whole process. And we've generated 2 manuscripts. One was published 2 years ago. This last one this year, they've simultaneously been published in the 3 journals of those societies. These have called for standardization of the valve descriptions and for clear labeling on the boxes. And that charge has been taken up by the ISO work group that deals with standards related to prosthetic heart valves. So we are making progress, but clearly the task ahead of us has all been laid out by the hard work done by these committees. One of the recommendations of the committee has been a standard valve chart that would be included with every valve, but also available online and via QR codes, so that one could know for a given body surface area what the expected probability is of patient prosthesis mismatch. You are familiar, of course, with these PPM charts, but the other valve chart would actually include from which studies these charts were based, and we would find actually in our reviews that very often these PPM predictive models are based on very few patients and not even all of the different sizes of a particular manufacturer's valve. It would show the implant positions and the various parameters that are measured. And again, these are not always trivial measurement tasks, but this is all part of an effort to make it, if you will, level the playing field so that one can compare one valve with another and also have standard metrics by which we can judge the hemodynamic performance and the durability. Even the effective orifice area based on postoperative echo has been challenged for its accuracy. And much of these technologies are used to actually evaluate the performance of the valve hemodynamically. This, we really need to get a little smarter and more scientific about how we evaluate these valves. Too many assumptions in the evaluation of these postoperative valves, and we need to improve the science. Finally, I just want to mention, as many of you probably know, there is a wonderful smartphone app, Valve in Valve Aortic. There's also one for mitral. This was developed by a cardiac surgeon, Vinny Babbitt, when he was at Guy's and St. Thomas's in London. He's now in Michigan in the United States, continuing this work. This app has a tremendous amount of information on virtually every available bioprosthetic valve. And it gives vetted information about the true internal diameter of each of these valves. Here's an Avalus valve, label size 23. This true ID is pretty close to that. This is a good one, but as I say, some of them are 4 millimeters off from the labeled size. But this was developed, of course, so that people doing valve-in-valve work could have good information, reliable information about the size of the old bioprosthetic valve. But I find that it's very useful in looking at the various commercially available valves in trying to make the right selection, the right valve for the right patient. So in summary, avoidance of PPM requires knowledge of the patient's hemodynamic requirements, which are largely the body surface area, the individual characteristics of the selected valve prosthesis, which until now have been somewhat difficult to get. I mean, certainly were not on the box, and judicious use of root enlargement procedures, which you'll hear more about in the minutes to follow. We do need to standardize the measurement of the valve characteristics, both their structural and their hemodynamic performance, and very clear, accurate, and truthful labeling needs to occur, and it needs to be on the outside of the box. And again, I really encourage you, if you don't have this on your phone already, to get this valve-in-valve aortic app available so that you can really start to look more critically at these valves that you take off the shelf to offer to your patients. Thank you very much. I think we have a few minutes for questions.
Thanks so much, Duke. Just to reiterate for the audience, the name of the app is Valve-in-Valve. And Duke, there is one question regarding FDA acceptance. Why does the FDA accept the absence of a standard sizer for all valves? And I was fortunate to serve on that group with you, and the answer is complicated, but certainly I think we'd love to hear your thoughts on that.
Well, I wasn't part of those discussions 15 years ago. It's actually very hard to find people who were there to explain the rationale. But I don't think there was malice. I think that one of the problems, quite frankly, is that surgeons have not been at the table enough in these discussions in developing standards and guidelines and trying to explain to engineers and cardiologists what the issues are at the operating room table. So I don't know that we have anybody to blame but ourselves, but we certainly have a much larger group of engaged surgeons now who want this whole process more transparent. Absolutely.
Thank you. I'm going to ask each of the panelists, starting with you, Duke, what is your choice, your bioprosthetic and mechanical valve of choice to avoid PPM in general, outside of the techniques that we're going to discuss later in this webinar?
A tough question, and I don't have a single answer. I have to tell you that I prefer porcine valves on the right side of the heart, and on the left side of the heart, I prefer pericardial valves for the aortic, and I actually still like porcines for the mitral. As far as the manufacturers, it depends on the size. I personally use the Resilia in the smaller sizes, and I'll go with a Magna or a Perimount for the larger sizes.
Bo, what do you have a tissue or bioprosthetic or a mechanical valve of choice that you might use, or does it depend on patient anatomy?
I actually, our institution, we use quite often is the bone and pericardial valve, the Magna Ease for bioprosthesis, and we also started to use in the Availus here. And a mechanical valve, I used the St. Jude valve before, but since I started the root enlargement, the two people got actually kind of in the way. So I use more top hat, and the biggest top hat it's about 27. It's supra annular implantation. Hemodynamics is great, and I haven't heard any mechanical problem in the literature for like several decades. So I use more top hat now, cosmetics, mechanical valve.
Ronald, what about you?
In the mitral position, I use porcine valves as well, like Duke. In the aortic position, if the annulus is on the small side, for sure, pericardial valves. We use both Edwards Magna valves and Avalis in that position. And for mechanical, either St. Jude or Onyx.
You know, Duke, you brought up, go ahead, Bo.
Oh, I was going to mention, you mentioned that the root replacement too. We use stainless valve, and for sometimes for the total root replacement, just upsize by like 2 or 3 valve sizes, just drop a root on top of the annulus. That will help with the hemodynamics.
Yeah, I think stentless valves are another option to avoid PPM. Duke brought an interesting point up in his talk about supraannular placement of the valves as opposed to intraannular. And I personally have always been a fan of supraannular placement of valves because I want I don't want to narrow the patient's native annulus because I believe PPM occurs when you narrow the native annulus. What do you guys do? Supraannular, intraannular for tissue valves? Duke, what do you do?
Always supraannular, but you know, the certain valves do have a profile into the outlet of the left ventricular outflow tract, the Onyx valve and St. Jude. So in a sense, they are considered intraannular valves, but the implantation technique, I always put supraannular.
How about you, Maral?
Yeah, same.
Yeah,
same.
go ahead.
No, same here. I think you're at times limited by the design of the valve, but the implantation technique is supraannular.
Yeah, I use supraannular for the tissue valve, and I do not use Pelagics. I think Pelagics crowded the LVOT makes annulus. When you finish the implantation, you look through the valve, you will see the annular tissue into the valve, which makes the valve size even further smaller. And then the 20, say like already from 29, label 29 is 25. Now you measure it, it's not 25 anymore. It's about 23, 24 because of the tissue. We do supraannular, the tissue inside of the valve. If you do intraannular, so there's no tissue there, but if we make the annulus big enough, then we can put intraannular, can maintain the 25 size for 29 valve. And but for most of patients I use the supraannular without Pelagics. I take small bites and annulars, so make sure no tissue get crowded into the inner circle of the valve.
That's right. I think we've touched on several important points outside of annular and root enlargement techniques that can impact any potential incidence of PPM. We've talked about the placement of the valve, supraannular versus intraannular, the suturing technique, and as Dr. Yang mentioned, there can be Pelagics or no Pelagics. That's one question from the audience. I have, during the course of my career, gone away from Pelagics because, as you said, sometimes when you use Pelagics, even when they're put in on the ventricular side, they can be seen protruding into the outflow tract, and that ultimately can cause turbulence, pannus formation, and PPM. And certainly I've witnessed that in multiple operations where we operate for PPM. So many things go into the determination of PPM, including valve choice, suturing technique, and placement. I think we should move to the next talk. Thanks so much, Duke, for an outstanding talk. We always learn something from you every time. Our next discussion will be Dr. Bo Yang, and he will discuss techniques of aortic, annular, and root enlargement and help us distinguish between the two techniques.
You can see in the screen, okay?
Yes.
Thanks for the invitation. And I will review some of transitional techniques and introduce the techniques we developed here and with a short video. And I will welcome any critiques. So as Duke just mentioned, here's a sample here. This is labeled 25 macula. Then they said the internal diameter is 24, which means it's not the orifice internal diameter. The internal diameter actually stands internal. The orifice, you can never pass a 24, you cannot pass a 22, you can only pass 21 sizer. Just confirm Duke's knowledge. And once you put into the patient, because of tissue get into the inside of the valve, I do not use Pelagics, the real diameter is further go down, can be 20 for 25, 22 for 27, 23, 24, 29. I do not use any valve now smaller than 25. So I expand the 23, you can see the inner diameter is 16. This mosaic is 14 here. This is 19 millimeter magnesium is 14. It's really a lot smaller than we thought. So my recommendation is for everybody on now, and when you put the valve in, just measure the valve. You can easily pass the sizer through. Don't force it because the red blood cells cannot force through that orifice. Gently push it through. That's the size you can get. That's the new annulus the patient will get. And if we put a a 25 patient come in with a 25 annulus. We put a 25 macula or valve, end up 20 millimeter. We downsize by the area by 36%. I have all the calculation here from 19 to 25 normal annulus. If we do not do the root enlargement, we downsize the annular area by 36% to 56%. So to me, anybody with a normal annulus without root enlargement will put a valve to match with the label to the size. It's a PPM. I just repeat this. If we do not do a root enlargement for normal annulus, we put the valve based on the label and the size of the sizer without root enlargement. It is a PPM. We reduce the area by 36 to 56%. Because of the significant downsize of the area, we have to upsize for 3 to 4 valve sizes. Look at this, it's 25 millimeter, we give a 29 valve, we still about reduction by 15% of the area. And you go to 19 to 23, you up 3 to 4 valve sizes, then we can either match the patient native annular size or even better to about 20 to 30%. So to me, the annular enlargement is needed and it's very important. This is a study we just finished. We compared our 2,000 patients and we divide the patient by the valve sizes and we did a KM curve. 29 had 10 years of valve, it's about 85 to 90. If it's 23 to 27, it's about 75, below 80. And if it's 21, 90 to 21, it's very low, it's about 55 to 60%. We also did the multivariable analysis. The small valve, it's a risk factor for long-term mortality. The hazard ratio is about 2 to 2.5. The paper is on the reviewing right now, on the revision. So that's why the root enlargement is very important. I want to just briefly review the traditional way to root enlargement. This is the first paper published in 1970 by Nix. He cut down through the aortotomy through the non-coronary sinus. If we do not go down, as I had mentioned before, the annulus, we can just cut through the non-coronary sinus. And when the patient annulus is big, 27, 29, you do not need to cut through the annulus. That's just a simple non-coronary sinus enlargement. Put a patch there, and you can put a bigger valve because the root is too small. The annulus is not small. We see patients often like this, and that's just a non-coronary sinus enlargement. However, you cut through the non-coronary sinus later. Actually, he cut into the left atrium too, the first paper. And there's also some mitral valve you can see here, and a patch it there. You can enlarge 1 to 2 valve sizes. If we do not cut into the left atrium and just cut into the aortic mitral curtain through here, we can upsize by 1. That's Nix. First one in 1970, great idea. 1979, Manugian, same idea, cut through the mitral valve and from the left non-commercial post into left atrium, because this cut is deeper than Nix. Through the middle of the mitral valve, give a bigger enlargement. Patch it, sew the atrium to the patch, and you can enlarge valve by 2 sizes. I think these 2 techniques have been used very commonly by adult cardiac surgeons. Pediatric cardiac surgeons, and 1975, Dr. Kono reported from Japan, just cut through the vascular septum straight down from the aorta between the right coronary artery and the left and right commercial post. Cut it open, 2 patches. You can enlarge the annulus. This is the annulus by 2 to 3 valve sizes with this approach. But this has a risk of complete heart block, and also cut into the right ventricle septum, become more complicated. And I think adult cardiac surgeons don't use this approach often. So those are the traditional ways, and I like to introduce our way how to upsize the annulus by 3 to 4 valve sizes. And we started last year, we had this idea. And actually this idea is coming from endocarditis. We did. Endocarditis patient, they destroy this part of the aortic mitral curtain, we patch repair it. And we'll never see any problem with patch repair this area. And one time I just cut the annulus open, I found out it's wide open. Then I was thinking how much I can cut, how much foot I can cut. So for now, we can cut all the way to the right fibrous trigon, but not into the membrane septum. Left to the left fibrous trigon, not into the muscle. If you cut into the muscle, you have to sew the patch to the muscle. It's a little more dangerous. Or below the naders. And with the Y incision, this distance is almost always 3 centimeters. The door is wide open, just posteriorly. You have transverse sinus posterior, a lot of space for this patch to go. So basically, we enlarge the parameter by 3 centimeters. If you divide it by pi, we enlarge the diameter by 9.5 millimeter, which is very easily to upsize by 3 to 4 valve sizes. And then put the valve stitches. The valve stitches is same as we just mentioned, non-inverting from the native annulus, just from ventricle to the aorta. There's 4 critical stitches and transitional. This one is the nadir of the left coronary sinus. The straddles the normal tissue on the patch. The further secure the corner here for excellent hemostasis. Same thing at the non-coronary sinus, nadir of non-coronary sinus. And also another transitional stitches from here. You go through the patch, this is suture line, the native aortic annulus, then patch to patch, then transition to patch outside in here. So I'm going to show a short video. I may pause a little bit of the critical steps and just for the audience, and let me know that takes too much time. So we started with the partial transverse aortotomy about 1 centimeter above, and you can see the annulus about 21 for this patient. So go from aortotomy straight down, divide the left and long commercial post. Yeah, then turn towards the left. I want to pause it here. So this is the muscular part. You never reach that part and just stop before that. And to the right here, same thing here. You cut underneath the aortic annulus. See, oh, I want to pause it here. So this is the membrane septum. This is the right fibrous trigon. You don't go there. You stop here. This is the nadir of the non-coronary sinus. So I cut it a bit more probably. Yeah. So you can see the posterior side is wide open. The door is wide open. It's always about 3 centimeters. If you are less than 3 centimeters, which means your cut is not that far. 3 centimeters is a little bit wider than the distance between 2 nadirs. So we'll anchor the patch with the left fibrous trigon to sew it to the aorta mitral curtain and the mitral annulus. Try not to go too deep. No, you don't want to disturb the mitral valve. This stitch goes through the right fibrous trigon and anchor it there. Then you transition to the nadir of the aortic annulus and go to the aortic annulus. Those tissues are very tough. They're annular tissue. So it's very easy to sew the patch for prolonged running and secure it at the aortotomy level. The left side, first stitch, I will go back to the area underneath the nadir of the left coronary sinus to further anchor the patch there, and then transition to the aortic annulus and come up to the aortotomy side and secure it with the additional stitches and tie it. So now you can see that the root is wide open. From 21, I use 29. And the size, I need to stop here. The sizing is very critical. Once you enlarge it, and you put you can always start with the 3 sizes up. Say it's 21, you can start 27 and the 29. When you size it, you mark what the size is and the patch for your sutures, valve sutures. The sizer has to touch 3 nadir of 3 coronary sinus. That's the plane your valve, the valve is going to sit, and it comes up a bit to the and the patch, because when we do without really enlargement, right? The aortic annulus it's like a crown shape, up and down, up and down. Same thing here. You go up and down, nadirs lower, and to the compression post is higher. That's all annular stitches. So and then you put a sizer there, touch 3 nadirs, and make sure 2 coronary artery ostia are not blocked. Then you mark your patch, mark the size on the patch. You want to pull the patch, straight the patch tight upward and mark it. And the highest place of the suture you put should not be higher than the left and long commercial post, which you are divided, which means you create a new left non-commercial post, either at the same height as the original native left non-commercial post or a little lower. by doing this, because the valve was sitting very well, won't tilt. It's just like a native annulus. So here's the valve stitches, the rest stitches like normal stitches. This is a transitional stitch. See that this is a nadir, this is a patch. So one stitch goes through the native tissue, one stitch goes through the patch here. And that anchors this part, the corner of the patch for the hemostasis. So hemostasis is very good. So the second stitch goes to the patch under the tissue. So here is not a transitional stitch. One stitch goes through the patch and the suture line annulus. One stitch just goes through patch to patch inside. So the rest is just outside in and the patch and the same. So this is the last transitional stitch here. I want to pause it here. So I always use one strut facing the left, the right compression post and start this stitch first through the valve sewing ring. By doing this, we guarantee to the left coronary ostium and the right coronary ostium are right on each side of the strut. And hopefully the nadir, even not the nadir, and won't be blocked by the struts. So that's how we position the three struts. The geometry all changed of the root because it's so large now. You don't want to the left and right coronary ostia be blocked by any struts. So I started this first. So see, this is the left coronary sinus, the nadir. We tied from the non-coronary sinus nadir suture first because that's lowest. We'll tie this part down first, then we'll tie the suture at the left coronary sinus, the nadir of left coronary sinus. So we anchor those down. Those are the lowest point of the valve. The rest just tie around it. And the root enlarges so much, it's very easy to tie. It's not a problem at all. I do not use corners, and it's never an issue. And the close the aortotomy is from the left side of the patch come up longer. Then you sew from the pulmonary side to the greater curvature. Then close the right side a little bit and trim the patch in triangular shape, and close the patch with the aortotomy. Put couple stitch on the right side, then you trim the patch from this part down there, then you close it. So this is the patch incorporated with the aortotomy. And this is good for aorta is not above 30. If it's aorta is about like below 30, I have a different technique I'll just mention later. So this is the whole technique for the Y incision rectangular patch. If patient has a bicuspid aortic valve, the aorta myocardium is not divided equally. On the left side, you can see the cut is much shorter, and the right side is much longer, almost 2 or 3 times longer. Well, the distance between the two layers is almost 3 centimeters. Once you put the patch there, it's the same. This is from 21 to 29. It's 29 valve. Mechanical valve do the same thing. It's a 21 to 27. It's about 3 centimeters here. And the patch, as I mentioned, this is St. Jude. I use top hat now. It's just the same thing as the supraannular implantation. So that's a change here. So the post-op CT scan show the valve sitting very well. There's no tilt. It's perpendicular to the blood flow, and there's no distortion of the coronaries. That's always a concern. There's nothing wrong with that. Mechanical, same thing, no distortion. And I have not seen any MR, worsening MR. So this is another modification of our technique lately. When the aorta is small, one patient have 90 millimeter aneurysm with the aorta, say 25. And if we do partial autonomy closure like that, it could form a kink or at the backside because the root enlarges so much, ascending is still 25. So we develop this roof technique. We make complete autonomy after valve implantation. We trim the patch into triangle shape. Then make a longitudinal autonomy at the posterior side of the ascending aorta and incorporate this triangular shape into the ascending aorta here. Once we finish here, And you can see the triangular patch incorporated into the ascending aorta to enlarge the HTJ and the proximal ascending aorta, which is very important for the future TAVR. And I found this on my iPhone. Actually, this is done by my chief resident, Dr. Sarah Palmer. And she said, "Oh, this is a roof technique." What do you mean roof technique? So then I found this on my iPhone. There's this icon there. This is really the patch shape. This is the house. This is the roof. And the roof technique here. And because we just incise here and sew it to the patch, the rest of the aorta still same match, exactly same size as the aortotomy, so they match very well. So we update the result about 31 patients now, and the median native size is 21, up to 27 median valve, and the annular valve size operates about 3 to 4, and intraoperatively the mean gradient is 6, LVOT gradient is 3, and 3 months post-op mean gradient is still 7, single digits, normal, and the mean gradient is 2, and I have been asked by many people about multiple people, we do not enlarge the LVOT. That's correct. We do not enlarge the LVOT because LVOT is normal in those aortic valve stenotic patients. The gradient is normal, and we do not put a valve into the LVOT. We put in the root above the LVOT. That's why there's no need to enlarge the LVOT. And the gradient, the post-op LVOT is absolutely normal. So there's no change, from 3 to 2. And the valve is wide open. And so that's, and I have not need to repair any patients with the mitral valve problem due to this root enlargement technique. So it summarizes here the benefit. If a patient, the same patient with 23 millimeter annulus, we enlarge to 29, give a 29 valve, I think obviously the better hemodynamics, better quality of life, better long-term survival, which is slide before. Likely the takes longer for 29 valve to be calcified and become severe stenotic than 23 valve because we started with a bigger size. And this 29 valve is much bigger, much better for future valve in our valve TAVR. 23 valve actually is not even a good candidate for TAVR because the inner diameter is 16, 17. So the conclusion is I think probably I'm biased, but I think any patient with a normal annulus need a root enlargement, need to have a valve up by 3 valve sizes to have a new annulus to match the patient original annulus. And the Y incision rectangular patch actually it's simple. It doesn't get into any structure around the root, and it's sold to the annular tissue, and it's effective to upsize the annulus by 3 to 4. So I'm supported by the NIH grant, and I have a great clinical research team.
Thanks so much, Bo, for that comprehensive look and sharing your unique technique. We have a lot of questions from the audience, but I think for the sake of time, I think we probably need to move on. There was one question about outcomes, and fortunately, our next talk, Dr. Maral Zunian, will be discussing clinical outcomes of aortic root enlargement. Maral, thank you.
Okay, thanks so much, Ed. It's really a pleasure to be here today on this with this great panel. I think the topic's very important, and we have to increasingly think about doing this for our patients in order to avoid PPM and give them the best possible long-term outcome. So in the time that I have, I'll go through what the early results are of aortic root enlargement, and then look at the data showing late results, which is actually quite limited, this data, and then discuss the very important issue about valve-in-valve TAVI and the role of root enlargement in those patients. So the first question that I'll pose is, does aortic root enlargement confer increased operative risk? And I'll start with our study from Toronto General with our data. This is my PhD student, Rodolfo Roca, who's now a cardiac surgery resident with us. And he looked at all of our aortic valve replacements from 1990 to 2014. We were quite liberal in the use of root enlargement. Bo said he would do it on anyone with a normal annulus. Chris Findell would agree with you, Bo. We did it, 1 in 4 patients had a root enlargement at the time of aortic valve replacement at our institution. And when we looked at unadjusted outcomes, when we looked at isolated AVR compared to AVR with root enlargement, the outcomes were not different. And we did a variety of matching, both regular logistic regression as well as propensity matching. And the bottom line is that in this fairly large cohort of root enlargement patients, we really found no increase in operative mortality. The odds ratio was 1.03, or any of the other important early outcomes, MI, pacemaker, and the rest of it, reoperation for bleeding. This is one of our medical students who then went on to look at all of the published literature in the topic and found 9 papers looking at root enlargement compared to no root enlargement. You'll see the sample size of these papers are on the small side, from a low of 30 up to 250, and a total of 2,500 patients who had root enlargement. Again, in this paper, after adjusting for baseline confounders, the risk of early mortality was not different between the two groups. As expected, the EOAI was higher with a root enlargement compared to without. And late mortality, this question was asked in the chat, it was only reported in 5 studies. Only 2 of those were adjusted with a mean follow-up of 7.8 years, and the late mortality was not different between the two groups. So this is just at the same time as our meta-analysis was published. This one was as well from Brazil. And I want to shout out to Michel, who is really excellent at disseminating cardiothoracic surgery literature on Twitter. If you're not following him already, you should. So he found one more paper, 10 articles total, and essentially similar results. Unadjusted, there is an increased risk of after root enlargement, but after you adjust, you see the confidence interval is a bit wide. But it does cross 1, and there's a benefit to lower patient prosthesis mismatch. It halves it by 50% after root enlargement. In these papers, the general rate of root enlargement was from a low of 6% to our paper, which was 26%. And when you look at the STS data, we have gotten better over time. So patients with severe PPM, leaving the OR after an AVR with severe PPM, has diminished over time in STS data from a 15% down to 6% in contemporary papers, which is encouraging. It tends to add 15 minutes of clamp time, 20 minutes to your pump time in most papers. So we can say, looking at the early data, that it seems to be a safe operation. Now, is there a late benefit to aortic root enlargement? This is our excellent cardiac surgery resident, Derek Tam, who during his PhD asked this question, and now using administrative Ontario-wide data. So this is 11 centers across all of Ontario, over 16,000 patients. A total of 8% of patients underwent root enlargement at the time of AVR. And after propensity matching, he had 809 very well matched pairs. And again, the early results were not different, a mortality of 2% in each group. And these are what the late results look like. So late mortality, these curves are superimposed. We don't find a benefit to root enlargement over time. Heart failure readmissions is also not different over time, and nor was any aortic valve reintervention in this cohort over time. Now, these data really come with a lot of caveats, and this literature is, we have to look at it very critically. The studies are all observational, almost all retrospective. We are lacking direct annular measurements. So now that we have, the benefit of many patients have a TAVI protocol CT scan, we have very clear annular diameters, areas, perimeters on gated CT scans preoperatively. It really behooves us to study this issue in greater detail. These papers are often missing very crucial data, including body surface area, EOAI, the valve type, the size, and especially postoperative echo gradients. As well, the definitions of and the patient selection is unclear. Certainly, surgeon's decision at the time of surgery of either enlarging the root or leaving a patient with PPM or using an alternative strategy, a stentless route, sutureless valve, or some other technique is unclear how that decision was made, and very limited sample sizes in these studies, with very few studies reporting late follow-up. So I really like that Bo looked at valve size and late outcomes. We're doing the same in Ontario, and I think it actually is important to late outcomes in patients. So shifting gears a bit, what about valve-in-valve TAVI and considerations around this? So everyone knows this, one of the most important early papers around valve-in-valve TAVI by Danny DeVere, published in JAMA. And the important message from this paper is that if valves fail by stenosis, or if valve-in-valve TAVI is done in a small surgical valve of less than 21 millimeters, the outcomes are quite poor and much worse than the alternative. And you'll see here that in a 21 millimeter valve, for example, the 1 year outcome, the 1 year death rate was 25%, so exceedingly high in this patient cohort. So that's an older study with slightly older valves, as is often the argument. This is a more recent study using both STS and TBT data of 1,200 valve-in-valve TAVI patients that were matched to native valve TAVR. And the finding was valve-in-valve TAVI comes with less mortality and, as expected, less paravalvular leak and less pacemaker, but at the cost of higher gradients. And the mean gradient leaving a TAVI with a valve-in-valve procedure was 16 compared to 9. And you can see that depending on what size transcatheter valve was placed, and on the left is balloon expandable, on the right is self-expanding, the gradients are lower with self-expanding valve. That's what we favor in the setting of valve-in-valve TAVI. If you're putting a small balloon expandable valve and even self-expanding in the small sizes, you're leaving the hospital with a mean gradient in the 20s, above single digit, way above single digits. So these patients do not do well in the long term. Philippe Pibarot, who's really done the most work on this topic, looked specifically at the question of pre-existing PPM on the outcomes of valve-in-valve TAVI in this paper in 2018, 1,200 patients. 8% had pre-existing severe PPM with an EOAI of less than 0.65. And as we suspect, and as both suggested as well, the time to surgical failure is shorter if you have severe PPM compared to if you don't have severe PPM. And I do think leaving someone with moderate or severe PPM does not do them any favors. These are the results of TAVI, valve-in-valve TAVI in the setting of severe PPM versus not. And you'll see they're actually terrible. The risk of leaving hospital with a mean gradient of over 20, that's how this was defined, was almost 50%, and 1 year mortality of almost 30%. So if you start off with severe PPM, you might as well not do valve-in-valve TAVI. It's not a good procedure because you'll be left with a mean of over 20 and your 1 year mortality of 30%. And this is adjusted, what the results look like on adjusted analysis, showing a twofold risk of death in the long term at 1 year if you do valve-in-valve TAVI in the setting of severe PPM. So really, as we're thinking about, as patients at younger ages are having bioprosthetic valves, the hemodynamic challenges with valve-in-valve TAVI are substantial, and leaving patients with high residual gradients with small valves and then putting a TAVI in that is it's a bad idea. The role of balloon fracture and these expandable stent frame valves really remains unknown. And our cardiology friends would suggest that we should just do TAVI and TAVI since explant data are problematic, but this is a problem, especially in women. If you look at partner data, 75% of women in all of the partner trials combined had a very small TAVR valve implanted. And so then putting a second additional transcatheter valve is going to lead to a poor outcome. And the index operation really is the key to future intervention. And it's off the topic here, but I will make the point that especially in patients with long life expectancy, we should consider a Ross procedure. We have very exciting data coming out. It's still in review, so I won't spill the beans, but comparing Ross to biological AVRs, and I think this option really should be considered in patients with long life expectancy. So to summarize the data, the aortic root enlargement is safe and does improve EOAI, as we've seen in multiple studies. However, the long-term benefits of root enlargement itself are unclear. We have not been able to show a benefit of root enlargement in the long term. However, we do know that patients with residual moderate or severe PPM do poorly. And so I would suggest that as a take-home message that we really think about future intervention and do the best possible operation the first time around. Thank you so much for your attention. Hopefully we have some time for discussion.
Thanks so much, Maral, for that really nice talk. And I think you've appropriately outlined several important points. Is that one, the data on root enlargement techniques are very good, but the emerging technology, transcatheter valve options, valve-in-valve options, we don't really know where the future lies. But most importantly, the first operation really matters, and it's important to think about the patient and the future potential interventions as you do the index operation. It's not just a matter of slapping a valve in and hoping for the best later on. We've got several questions from the audience, and many of which are very nuanced, but I thought it might be a good idea to ask the panelists, starting with you, Maral, what is your root enlargement technique of choice, and how do you determine when to do a root enlargement versus an AVR? And we kind of know what both things already here. So let's start with you on sort of, with your thoughts.
Yeah, I think a lot of it depends on the age of the patient and the expected life expectancy, and how likely you think that patient will be to need a second intervention in the future and their comorbidities. So if I'm doing an elderly, small BSA woman with grafts as well, and she needs 3 or 4 grafts, she's in her 80s, I'll probably put a sutureless valve and then not do a root enlargement in that patient. In someone who is more robust, I would favor, on the other side of that is the Ross procedure for sure. So even into their 50s and 60s, I think a woman with a very small annulus, even if she's in her late 50s or early 60s, if we expect her to have 20-year life expectancy, most root enlargement techniques don't get you that much larger of a valve size. And I'm, I think Bo's technique is excellent. I'm excited to try it, and getting 2 or 3 or 4 valve sizes greater. I mean, that's a huge improvement to what we typically have. In general, I would do, if it's only one size bigger that's required, a Nix or a Manukian, I favor a Manukian or a patch of non-coronary sinus if it's really only one size larger that's needed. That's a very simple technique to place the valve slightly higher in the patch. You just need to be aware of where the coronary arteries are in that technique, and not be left with a really tilted valve in that situation. You obviously have to get through the annulus to make a substantial improvement in the annular size. And I think Bo's technique is excellent.
Thanks, Maral. As Dr. Azouzian has clearly outlined, a lot of factors go into the decision-making in choosing the appropriate operation for a patient, including age, comorbid medical conditions, and patient anatomy. And I think all of these things should be taken into account, and really it should be not a one-size-fits-all. We must individualize therapy for the patient for the optimal outcome. Duke, if you could elaborate on sort of your thought process to root enlargement, how do you use it in your overall armamentarium?
Sure. The first thing I'd like to say is I agree 100% with Maral. I think the Ross procedure is a great first operation for young people. I think in the long run, it's gonna turn out to be one of the most durable things one can do. Second, I am reluctant to go cutting into the mitral valve. I'm just worried about the long-term results of that. I know Bo's results have been great so far, but 10, 15 years out, I am worried. So most of the time, I'm just enlarging the non-coronary sinus can tilt the valve up a little bit, not have to get quite so extensive. And if I need to do more, I'll usually replace the whole root, just a standard Bentall. But my bias is to stay out of the area of the mitral valve. I'm really interested to hear Bo's long-term results too. And I have a question too for Bo, if I could just sneak this in real quickly. How good are the data that a 29 millimeter bioprosthesis is really going to last a lot longer than a 25? This is a lot of extra surgery to get 4 millimeters on the same valve. Super.
That's a good question. Yeah, we do not have that data. Say 25 lasts longer, and my thinking thought is same patient without root enlargement has a 23 valve, with root enlargement is 29 valve. I use pericardium, which is calcified, and the most time this structural deterioration is the calcified stenosis, restenosis of the valve. To me, will take longer for 29 valve to become severe stenotic than a 23 valve. That's just assumption, but we do not have data to support that yet. So, we did analyze the different size and the reoperation and deterioration. We found out that the smaller valve patient just died. They died, so they are not. They don't have reoperation because they died, and the mortality is so high. And the large one had the reoperations, but they live. So yeah, and back to your mitral valve, I completely agree. That's why I don't cut into the mitral valve at all. Everything from the Y incision is above the mitral valve, above the right atrium and the left atrium. So I purely just enlarge the root without touching any structure around the root. So that's why it doesn't disturb the function of mitral valve. So as I said, this is just 1 year experience. We need a 10, 15, 20 years experience to see how it works. But so far it works very well. Yeah.
There's been a lot of questions about the patch material, bovine pericardium, Dacron. What do you guys think?
I would not use bovine pericardium because I have done so many redo bovine pericardium put by my senior partner. The redo, there's no way you can put any stitches through the calcified bovine pericardium. I did the redo conal because there's bovine pericardium patch. They have to take everything out, repatch it. And also any patch bovine pericardium after 10, 15 years calcified, it cannot put any stitches through, and they have to take the whole thing apart, rebuild up everything. So I would not recommend bovine pericardium because of the calcification. And I use HemoShield because it's easy to put it there. Oh, one thing I want to tell every audience is, I had one patient had endocarditis. I have to take this patch and everything out. Very interesting finding is the patch underneath the valve, it's all become endothelialized, smooth, covered with tissue. I think that the cells, the fibroblasts and the endothelial cells from the mitral annulus and aortic annulus grow over. But above the valve, which is exposed to the aorta, it's not covered by any tissue, as like we normally see in the aortic graft. It's a very distinguished feature. So I'm happy with the HemoShield patch.
Thanks, Bo. Maral, what do you think about patch material? What is your?
I use bovine pericardium. It can calcify in the future, but that's what I use. I'm interested in what Duke uses and also what your approach is, Ed, to the technique.
Yeah. Duke, what do you use for patch material?
I use bovine pericardium, and I can tell you that Dacron and HemoShield calcifies just as much. Whatever you put in there that is not living tissue is going to be very calcified at 10 and 15 years. I don't think there's a difference. I've tried to sew, put pass needles through old VSD patches or RV outflow tract patches that are Dacron, and it's just impossible.
So Maral, I also like Duke. I'm a little hesitant about cutting into the mitral valve. So if I do any type of enlargement, it's going to be just isolated to the root patch above the annulus. I typically have not done, the Nix or the Manugian procedure. In cases where you have to get a bigger upsizing, because as you astutely said, you can only really upsize by 1, maybe 2. That's the intriguing thing about Bo's technique. You can really upsize by 3 or 4. If I've had to upsize by more than 1, we've done a Kono procedure. But I like Duke. If I have to cut into the mitral valve, concerned about that, I think I just go straight to a root replacement. I think the most important thing when you think about PPM is not to iatrogenically narrow the patient's native aortic valve annulus. That's the key. I can't tell you how many valves I've taken out of patients where the valve, once we took it out, debrided the annulus of all the suture material, pledget, sewing ring, the original valve could slide through the patient's native annulus because that patient clearly had an operation where it was done in sort of a convenient for the surgeon, not convenient for the patient. And which is conflict of interest because we want to do what's best for the patient, not necessarily what's going to get us out of the OR. But in any event, I think that, so I do think this has a role here, but it's very important to really never narrow the patient's native aortic annulus as a way to prevent PPM. There was one question that I think we were 5 minutes over. Can a redo AVR be more difficult when a root enlargement was performed the first operation? I think in that situation, you're probably looking at doing a root replacement, quite honestly, because to kind of put all that back together is going to be very difficult. This has been a
Can I make a comment on that just quickly?
Real quick,
1/3 of my root enlargement is redo. Redo will be more difficult because you need to really identify the aortic annulus. So I still do the root enlargement for redos from 19, most time it's 19 or 21 up to 25 or 29. So you just have to identify the aortic annulus.
Thanks so much. I think we've learned today that the issue of root enlargement and preventing PPM is a very complex subject matter. It's nuanced on multiple levels, including patient medical conditions, patient anatomy, and obviously lifestyle consideration, and there are multiple options. And then the transcatheter valve therapy is going to offer us even more techniques to treat patients in the future, provided the index procedure is done first. As with any patient, the key here is that we individualize the therapy to optimize the care for the patient. Thanks so much, everyone, for your time. And wherever you are, again, across the globe, we appreciate your interest. Thank you to CTSNet for putting this on. And I think this will be recorded and put on, this has been recorded, will be live later for subsequent review. Don't ever hesitate to reach out to any of the panelists or myself for any questions. I know that all of us would be happy to answer those. Have a nice weekend and be safe, everyone.
Can I make a suggestion? All of us just can answer the questions from the chat if we have time.
Oh, Chris, are we allowed to stay on or?
Do I have to stay on? I don't. Oh, okay.
I think people are leaving. We'll just look at your inbox, but we're in good shape. All right.
All right. Thank you. Good to see you guys.
Great to see everyone. Thanks so much.
Bye-bye.